You guys are so welcome. It's hard to speak like this because usually I can like see the room, but I'm super, super excited to be able to tell you guys about what I do as an ER doctor. I know your host told me you guys had a emergency medicine resident speak to you about a week or so ago, and he gave you some great insight about the path to emergency medicine and scores and alternative pathways and things like that. So I'm going to give you a little bit more of a like a nitty gritty. What does it feel like to be an emergency physician, and what do I do on a day-to-day basis? I am a board certified emergency physician. I work at a academic level 2 trauma center in Detroit. We can talk a little bit more about what that means to be academic and a trauma center a little bit later in the presentation, but that's kind of my background. So if you guys have questions during the chat, I'm a pretty informal person. I would be more than happy to answer as we go along. I am going to try to monitor the chat, but we'll kind of see how that goes. I'm going to kind of ask your host to help me out with that. So, all right, we'll kind of get moving. So this is where I work. This picture is the front door of our hospital and our emergency department. And these are some of the signs we had put up during COVID-19. The picture that you guys have seen and the picture on the first slide was me all in like full battle gear for COVID-19, which is something that emergency physicians have been on the leading front of since March. So it's a super, super amazing time to be considering emergency medicine as a career and to be working in emergency medicine. Okay. So you guys have probably heard that a emergency physician is a jack of all trades, master of none, and I beg to differ on this one. So this is not my trauma bay at our shop, but it might as well be. It could be. It's like the place in the emergency department that gets the most messy, the most bloody, and it's also like the only place in my life where I can just open up packages and throw them on the floor, and somebody else is nice enough to be able to pick up after us. So, but this is what, this is like, if you are called to emergency medicine, a slide like this makes you so super excited. There's so much stuff that happens in these resuscitation and trauma bays. So I would consider an emergency medicine physician not a master of no trade, but a master of what I would consider resuscitology, which is the art and the science of saving lives. That is what we do probably better than any other specialty, is being able to get in there when time and minutes and seconds matter and make an impact, whether that's for a person with an acute traumatic injury or somebody with a life-threatening medical condition. An emergency physician is specifically trained to be able to function in that kind of intensity, that high degree intensity environment, to make decisions, often with incomplete information, and to kind of be comfortable moving forward with those decisions and being able to not freeze up when things get really crazy, but to keep doing what we've been trained to do to take the very best care of patients that we can. So this picture right here, more than probably anything else I'll show you today, is what being an emergency physician feels like for me. Sometimes it's totally crazy and it's busy, but there is so much satisfaction in being able to actually get in there and save somebody's life and make a difference. So if anybody else kind of gets all the feels, I guess, from a picture like this, then maybe emergency medicine is exactly what the specialty is that would suit you best. Okay, so I talked about where I work at an academic center, a level 2 trauma center. So where do ER doctors work? Because it's not all the same. Just like in many other areas of medicine and practice, there are different kind of sites that we work in. So an academic center means that there are residency programs associated with the medical center. So that's mine. We are affiliated with Wayne State University. We have emergency medicine residents. There are 12 of them every year, and an emergency medicine residency is either 3 or 4 years, depending on the program. Our program is a 3-year residency. So almost every shift I have, I work with a resident physician. So that's a learning physician, and I'm the supervising doctor. There are also what we call community hospitals, and those would not be affiliated with a medical center, I'm sorry, with a university or residency program. Those are attending emergency physicians only. And so being an attending means you've completed a full residency and you're board certified and you're able to work completely independently. So in a community hospital, an emergency physician would, like an attending, would not be working directly with a resident physician. They're working on their own. So that's kind of a different feel of a practice environment. For those of us who really love to teach and who love to kind of be involved in the education and furthering our specialty and research, an academic center feels right. But there are lots of people who just want to be an amazing physician, take care of the people in their community, and those people often choose to work in a community hospital. And then not all hospitals are created equal and not all hospitals are the same. So there are what we call trauma centers, and that's a verification and a certification by the American College of Surgeons, actually. And then every state is a little bit different, whether your state also verifies and certifies a trauma center. So the trauma centers they have a special distinction. We have special resources available. They are levels 1, 2, 3, and 4. Level 1 and level 2 are certified by the American College of Surgeons. And those are indication that you're able to care for the sickest of patients in the highest acuity environment, and you have the most broad resources available to them. Most of the time that includes all of our friends, all of our subspecialists that are available. Our trauma surgeons, our neurosurgeons, our orthopedic surgeons are all available to us 24/7. And that's what makes my trauma center kind of different than a smaller community hospital or a level 3 or level 4 trauma center. The difference between a level 1 and a level 2 trauma center really is focused on research. So while I say I work at a level 2 trauma center, we actually, where I am, see more trauma than anywhere else in our city. And trauma is either blunt or penetrating. So that's the gunshot wounds, the stab wounds, and the car accidents are kind of the biggest ticket items in our trauma bay. I see in the chat, could you moonlight at community hospitals during your residency? That is a residency program kind of specific choice. The residency, the Graduate Medical Education Office, GME, which governs all the rules for residencies, says yes. And individual programs deal with that differently. Some programs will allow you to moonlight in your 3rd year. My program where I trained, we could moonlight in our 3rd year as long as all of our other residency obligations were going well. So as long as we were doing well on our in-service exams. So as a resident physician, you take an exam every year that mimics what will be on your final board examination. And it's a way to make sure that you're moving through and learning what you need to learn so that by the time you're finished and ready to take boards, you're good to go. And there's a very low chance that you'll fail your boards because that would be kind of a disaster. So yes, sometimes you can moonlight and sometimes you can't. It just is totally, completely independent and dependent on the residency director. There are also a lot of emergency physicians who work in a rural environment. Sometimes, the emergency doc will be responsible throughout the entire hospital at night for managing patients who are acutely crashing or in cardiac arrest. That's not something that's possible in a big center like where I work, but in a smaller environment, it is possible that you are the only doctor in the hospital overnight is the emergency doctor. And you may be covering issues on the floor and things like that. So you really need to be well trained in a very broad range of medical conditions and management, what makes emergency medicine so awesome and like so comprehensive. And it's why I absolutely think it is by far the coolest specialty. And I'm sure all your shadowers say that, but I absolutely completely love my job. How do you deal? I see in the chat, how do you deal with the high stress situations in emergency medicine? I'm going to leave that for a couple more slides down the road here, and we can talk the good, the bad, and kind of the ugly of what happens in emergency medicine. Okay, so a day in the life of an ER doctor. Um, we work shifts. All of us work shifts in varying departments. That shifts looks different. Right now, where I work in the intra post COVID world, we work 8-hour shifts. Prior to March, we were working 9 hours at a time. So you see the shift times listed here of 7A to 3P, 3P to 11P, and 11P to 7A. Previously, those were all 1 hour longer, allowing us to overlap one another for an hour to kind of make sure we can kind of tuck everything in and our patients, and we can be able to leave the emergency department on time. Since COVID hit in March, our emergency department volumes are about 70% of what we would expect them to be this time of the year. And so that means we have had to shorten our shifts because we can't pay doctors if we don't have as much volume as we previously did, which is kind of crazy. We're in the middle of a pandemic and our emergency physicians are getting hours cut, but that's a topic for an entirely different situation. But this is what we're working right now, 8-hour shifts, no overlap. And so depending on how busy an emergency department is and how many patients come in throughout the course of a day will depend on how many providers are in the department at the same time and how long your shifts are. Some shifts are 12 hours, some are 9, 10. It's completely dependent on where you work, but this is what I do. So we come in, like I worked all weekend. I worked the day shift all weekend. And so that starts at 7 o'clock in the morning. And the first thing we do is take sign out because, like I said, an emergency doctor works shifts, which means that I take over for the other doctor when they leave the hospital. And when I'm ready to go, I hand off all care to the next physician. So we spend some time signing out, kind of handing off what's been going on with Mrs. Smith, who's got chest pain in room 2, and Mr. Jones, who maybe is having a stroke in the other room, and that MVC who came in last night that we're waiting for the trauma team to disposition. Then we see patients. A typical emergency doctor will see about 2 patients an hour on a shift. That's kind of like a benchmark of what a lot of us see. Obviously, things vary place to place, and if we have residencies and things like that, but usually I see about 2 patients an hour. Like I said, there's no overlap between our providers right now. So when I'm done seeing all my patients, I sign out, hand off, and head home. And the awesome thing about working a shift as emergency physician is that you're not on call, which means when you leave the emergency department, you're really done. Like you're really done and you can really be off, which means a lot of the rest of your life can be whatever you want it to be. I see some other comments in the chat. So did I consider any other specialties when I was in medical school? Yes, all of them. I think that's pretty common for an emergency physician. We kind of like everything. Let me get down the road a couple more slides too, and I'll be able to kind of speak to why a lot of us like everything and why that is sometimes a hard decision going in through medical school. And yes, I will tell you why I chose emergency medicine in just a minute too. If I can get this go. Okay, so this is our board certification body, the American Board of Emergency Medicine. And during COVID, they did a huge thing and put some stuff on about all of the things that we were doing. So this is me again in full riot gear on the ABEM page. Okay, so here we'll be able to speak a little bit to the question of did I consider anything else and what kind of we do as emergency physicians. So what we would consider like our bread and butter chief complaints and pathologies we see as emergency physicians are somebody with chest pain. So we have to determine, is that somebody, when they come in with chest pain, do they have a heart attack? Do they have a cardiac arrhythmia, like their heart isn't beating the way it's supposed to be? Or maybe that means they have pneumonia, or maybe they have a broken rib from an assault or a car accident. Difficulty breathing is another complaint we see frequently. Is that asthma? Is that congestive heart failure? Again, is that pneumonia or something else? Do they have a collapsed lung maybe? Abdominal pain. Here, Is it a young woman who is pregnant? Does she have an ectopic pregnancy, so a pregnancy that's not in the right location? Is it an older man, and maybe he's having what we call like a vascular catastrophe, something wrong with his aorta, the largest vessel in the whole body? Or is that a new diagnosis of cancer that's just kind of lurking there? And then we take care of lacerations, so cuts that need stitches and broken bones. And these are things we do kind of like day in and day out. So you'll see by looking at this list of things that we do like maybe a little cardiology and maybe a little pulmonology and a little OBGYN and a little pediatrics if that kiddo has fallen and cut themselves or broken their arms. Somebody comes in with a stroke, we do a little neurology. So I think often emergency physicians really, really like the incredible like differentiation of things that you're called to do in a day. It's something that is fun, right? Like you never have the same day twice as an emergency physician. And it always kind of keeps you on your toes because you never know what's going to walk in the door right behind this, the patient that you're seeing right now. So let's see, like this weekend, we have somebody comes in with, a young person with chest pain. Well, I think probably that's not going to be a heart attack, but maybe it's a pneumonia, or maybe their heart isn't beating normally, like a cardiac arrhythmia, like we called. So we're in the middle of working that up. And then our tweeters, which is what we call the alert system overhead that announces a critical patient goes off, and we get pulled into resuscitation where there's somebody who's jumped off a bridge 60 feet. And so you just have to be able to like flip back and forth. And that's part of what makes it super, super fun to be in the emergency department. Okay. So yeah, I did consider literally everything else. My medical student friends would like laugh because when I was on surgery, I would say, oh yeah, I'm going into surgery. And then we'd flip and we did OB/GYN. And I said, oh yeah, GYN for sure. But I ended up being in emergency medicine. I was a EMT and a paramedic. So I knew probably junior year in high school that I wanted a career in medicine in general. And I went to college at the University of Michigan in Ann Arbor, and I decided to take an EMT class. I wanted something to be able to add some weight to my resume. And so I took a class there. In the chat, EMT is a lower licensure level than a paramedic. An EMT does some basic first aid stuff and some kind of low level airway stuff. And then a paramedic is kind of like a doctor in the field. They do all of the defibrillation and somebody who's having a cardiac arrest, they push medications, they intubate, they're kind of like the full deal. So I did that, and I totally completely fell in love with emergency medicine and pre-hospital care. And so when I was a junior at Michigan, I took the paramedic coursework along with my coursework at University of Michigan, and I worked in the pre-hospital environment for 8 years. It was awesome experience. It absolutely gave me a huge foot up when I was looking to apply into emergency medicine residencies, and it really kind of like solidified why I wanted to do what I wanted to do and that it was the right choice for me. I saw in the chat a little bit ago, was I ever worried that emergency medicine wasn't the right choice for me? No, I love it. I love emergency medicine. This is a great fit for me because there's so much that you can do. I see also in the chat, psych, yes. Psychiatric emergencies are another enormous piece of what we do as emergency physicians. So no, the great thing is though, if you are an emergency physician and you realize that you don't like a portion of your practice, like we talked about, emergency physicians work at academic centers, and they work in community centers, and they work in rural medicine centers, and they work in trauma centers. Some emergency physicians would choose maybe to work in an urgent care or another type of environment. You have lots of options as an ER doctor. If you don't like, you don't want to work with residents, that's fine. There's a place for you. Or you do want to work with residents, that's fine. There's a place for you. You want to see trauma, you want to see kids, you don't want to see kids. There's all sorts of options. So that's the bread and butter of what I would consider my emergency medicine practice is, the chest pain, abdominal pain, difficulty breathing. But here's the really, really fun stuff. And most of us emergency physicians are sort of adrenaline junkies. We like that resuscitation picture that I popped up first. We like to get in there with our hands and we like to fix it. So what I would consider the really fun stuff is often, unfortunately, not really fun for the patients, but it's awesome learning. Those are the gunshot wounds, the high-speed motor vehicle collisions, the cardiac arrests, severe respiratory distress, and then all of the procedures. So emergency medicine is a procedure-heavy specialty. And I'll walk you through some of the things we do in just a couple more minutes. So we have the stuff we see all the time, and there's lots of moments and even full days in emergency medicine that it's not super glamorous. You may be seeing somebody with a stuffy nose because they couldn't get into their primary care doctor. And then you might see somebody with belly pain and it turns out to be just some acid reflux, and then you might check somebody for an STD, and it's kind of like being an internal medicine or a family care doctor, but you're there all the time, you're available for anything. And then the tweeter will go, and then something really high intensity comes in. So emergency medicine is not high intensity all the time. We'd totally burn out if that was the case, but it's a really awesome mix of being able to do high intensity medicine, high intensity procedures, really, really complex medical decision making, interspaced with things that aren't as complex and not as high level intensity. And the variety is great. I love seeing kids. I like seeing women. I like seeing men. I like seeing trauma. So I didn't want to do like just pediatrics or just OBGYN and then really only focus on, the female medicine. So I like to do kind of all of it. And the question about, is there a personality type for an emergency physician? I mentioned most of us are like very comfortable with making decisions with incomplete information. There's an aspect of kind of a adrenaline junkie, I guess. Somebody who is looking for a high intensity environment that changes frequently. You have to be able to get to do those kind of things and be comfortable with those kind of things to be able to function well in the emergency department. A urgent care physician often is not board certified as an emergency physician. Often an urgent care physician is internal medicine or family medicine that is moonlighting. They see the lower acuity things, typically the sniffles, and somebody who's having maybe a urinary tract infection, and urgent cares don't have the ability to run as many tests as an emergency department does, and they can't admit patients. So typically they're not quite as thoroughly trained in those specific emergencies as an ER doctor. Okay. Airway management is one of the most fun things we do. This is me with a bag valve mask. So if you need to be intubated, this is going to be like your last look before we kind of put you to sleep and take over breathing for you. I mentioned before procedures that we do, and I do see in the chat about interesting cases and work-life balance and medical school and things like that, and I'll touch on those in just a few minutes. So some of the things we do to take care of patients is procedure-based. So if you have an interest in maybe surgery and you like to actually do and build and make with your hands, emergency medicine fulfills a lot of that. We do abscess, incision, and drainage. So somebody has an infection and has developed a collection of pus. We'll drain that, which can be kind of gross, but really satisfying because you get to take care of the problem. We put in stitches, we splint or cast if somebody has broken a bone. We do nerve blocks and sedation to provide pain relief for patients who need to have a bone put back in place. For somebody who needs to have a stitch done, we put advanced monitoring in, like a central line if we need to give patients medications called pressors to keep their blood pressure up if they are, in septic shock or critically ill, arterial lines to measure blood pressures. And then on this right column, these are kind of the more high intensity procedures, a cricothyroidotomy. It's kind of one of those movie moments when you cut into somebody's neck to put in an airway. If we needed to do that, a perimortem C-section would be when a woman in later part of pregnancy would come in not breathing and without a pulse and cardiac arrest. And we are trained to be able to do a C-section in the emergency department to deliver baby. Thankfully, it doesn't happen very often. I've been involved in a few chest tubes. So that's putting a tube in the side of somebody's chest to reinflate a lung. The same thing with needle decompression. Thoracotomies, again, are a rare procedure in emergency medicine. My department is busy enough that we do these pretty regularly. It's like somebody would have a gunshot wound or something and we need to get access to their heart. Lateral canthotomy is a procedure to release some pressure around your eye. And then we have a lot of use of ultrasound. So you can see the number of body systems we interact with, the number of and different type of procedure is really varied. And like again and again, I keep coming back to the fact that emergency physicians are really broadly, sorry, my cat is climbing, like broadly skilled and broadly trained. Okay, taking a peek at the chat. You've been interested in psychiatry. We do a lot of that. We do a lot of psychiatry. We have a lot of psychiatry, and emergency medicine is super, super fun. Okay. The not so fun stuff about emergency medicine. Every specialty has what, make it really super awesome. But I would be completely remiss if I don't tell you about the difficult things, because I think to make an informed decision about what specialty you want to go into or what you want to, do as far as a career, even if that ends up being not medicine, you have to go in with your eyes open and understand that it's not all perfect. So emergency physicians do work nights, we work weekends, and we work holidays. What that breakup looks like is going to depend on the kind of group you practice in and whether you practice as a full-time clinician or whether you kind of specifically treat or specifically work in administration or something of that nature. I am part of our administrative team. So I am the medical director for our emergency department, which means I don't work as many clinical hours as some of our other physicians. I work 1 to 2 nights a month, which is more than enough for me. The night crew is usually a really fun group of people, but they're hard with the rest of my family life. We do have people who are nocturnists who work only nights, and I thank God every day for them because it's not something that I want. But if you're somebody who absolutely hates getting up early in the morning, but you like procedures, and you know that being a surgeon means you would have to get up at 4 or 5 to make it into an early morning case, emergency medicine and a nocturnist might be something that fits really well for you. We do work, like I said, we work weekends and holidays, but it's a trade-off. I know my schedule right now through the end of December. Some groups schedule further out than that. So while my shifts vary, it's kind of like a controlled chaos, which is also a thing that the emergency department feels a lot of days like controlled chaos. It is shift work. So when I'm not in the hospital, I'm not in the hospital. So we just make a plan for when I'm working on the weekend or working on a holiday. So sometimes that means the birthday is celebrated the day before or day after. Sometimes that means that Easter morning or Christmas morning is celebrated the week before with family, and emergency physicians have a variety of ways that they make that work. It just depends on what is best for everybody's individual family situation. Giving bad news. Yeah, that is something that is hard to learn to do. It's not something that's really particularly well taught in medical school. And it's something we do fairly often in the emergency department, especially where I work and with as much trauma as we see. Every time I have to tell a family member that it's particularly hard if it's a trauma and they're young, if I have to tell mom that her 18-year-old son was shot and is dead, my hands shake, my heart pounds. And I've been doing this for almost 10 years since I started residency training. And I think the day when I don't feel that going in to tell families and patients bad news is probably the day I should consider stopping practicing emergency medicine, because there is an art and there are techniques that you can use to tell bad news. But if you don't feel that as a human, then I don't think you're appropriately connecting with your patients. So yes, we do as doctors in medicine and in emergency medicine, we do compartmentalize. We can't take every single patient encounter and every single bad thing home with us, but we like to be a fantastic physician, no matter what specialty you choose. I think the best doctors are the best humans, not the people with the best board scores, not the people with the most extracurricular activities for their CV, the best humans, the people who really want to connect to patients and families. And you absolutely can comfort a patient and still be a professional. We have chaplains and things to assist, but I think it's completely reasonable to touch somebody on the shoulder or the arm when you're giving them bad news. Some of our patients have gotten up and hugged me, and that's okay. Sometimes they don't want to do that, and that's okay too. So I think the best way to learn to deliver bad news in the emergency department or in whatever specialty you choose to work in is to watch somebody who does it well. And you'll be able to figure out pretty quickly who does it well when you kind of watch it happen. And you'll be able to see quickly like how families respond and things like that. So I think it's an art. This is truly, truly where medicine is not a science. Medicine is an art when you learn to connect and learn to give families bad news. And it is by far the worst part of my job is the bad news bears part. But it means I've tried. It means that things maybe haven't gone as I would have hoped. But I know in my heart that if I wasn't there, the outcome would have certainly been death in so many of these cases, and that we've done everything we can to give this person the best shot. Have you ever cried when giving bad news? I have not. I'm not a super big emotion person, so that's not something that I have done. I do have colleagues who have, and if that is who you are, it's not unprofessional to get a little misty-eyed when you're telling somebody that their family member has passed. I think it's human, and that's completely fine. And if you're the kind of person who is not like, that's not you don't feel the need to cry, or that's not, that's okay too. So what are the phrases when I give bad news? Yeah, so in the emergency department, I usually start with like, so tell me what you know so far. And that gives me a good jumping off point. Sometimes families tell me that they already knew that their loved one had CPR performed, or our community is really close knit. And so sometimes the person who has had the gunshot wound has a friend or a family member on scene who has called. And so they kind of have a picture of already what's going on. And frequently I'll tell them, and it's important to be fairly direct when you tell somebody that their loved one has died. They do need to understand that. And sometimes that sounds callous when you say they're dead. But it's important as the physician not to use some kind of like they've passed on or some other softer way to put it, because it is very important for families to kind of like understand that. And if it's a person who has come in and their loved one has done CPR, their loved one has called 911, I make it a priority to tell that family that they did the right thing, they did a good job, they gave the person, their loved one, the best chance that they could have to surviving the incident. And you know, because people are trying to do the absolute best they can with the resources and the information they have at the time. And I think it's nobody, you know, nobody wants to feel like they did it wrong. And so that's something that I prioritize in my practice. But again, like this is just what I do as an emergency physician, and many of my colleagues do this kind of thing too. Okay, so is there something you wish I knew before I started emergency medicine? I feel lucky that I spent those years in EMS before I started into emergency medicine, because I think I got a good eye-opening picture of what it's like to be in emergency medicine. I saw the doctors and nurses in the emergency department at all the hours I was. I saw some of that kind of stuff. I knew the variety. I think when you're thinking about specialties and about emergency medicine in particular, you have to kind of really ask yourself if you can handle like the extremes. Are you going to be able to function in a high intensity trauma? And are you going to also be able to care with passion, compassion, and respect for somebody who is not having what you would consider an emergency, but what they would consider having an emergency, like an STD or like a urinary tract infection. So those are kind of some really important things to understand as well. I also think it's important to recognize that while everybody takes a different path into the specialty of their choice, unfortunately, board scores and performance in medical school do matter. You don't have to have the top board score, and it's not impossible to get into a specialty if your board score is lower than the average. But having scores that match up with the specialty you're interested in will make it more likely. I don't want to, discourage people from pursuing something that they're passionate about based on a board score, but at the end of the day, like, I think you have to be honest with yourself about that. Also, I think you want to consider the kind of life that you want to lead outside of medicine. You guys can look up, depending on region, compensation. So like the dollars that emergency physicians make every year. And I think you kind of have to be able to look at your student loans, the environment you live in, the kind of house you want to have. Do you want to work part-time? Do you want to work full-time? Do you want to work in academics? And look at those salaries and decide if that dollar figure and your loans and your lifestyle are going to match. Again, it's not the be all end all, but I think this is your career and this is your livelihood. And so having some conversations and thought process around what that means for not just life in medicine, but life outside of medicine is particularly important. Let's see, I've got a couple more slides. Okay, so you guys have had some other questions about like, what else do emergency physicians do and kind of like how I deal on a day-to-day basis. Like I said, I'm in administration. The cool thing about emergency medicine is that it lends to so many other opportunities. Emergency physicians more and more often are choosing to do fellowship. So that's a subspecialty training after you finish your emergency medicine resident. I'm board certified in EMS. I kind of got the pre-hospital bug and interest long before I even started medical school. Ultrasound, critical care, pain management, palliative care, toxicology. PEM here is pediatric emergency medicine. So you can do emergency medicine and then pediatric emergency medicine as a pathway, or you can do pediatrics and then pediatric emergency medicine. Sports fellowships, global medicine, and medical education are just kind of a few of the fellowships. So if there's something that you like really want to do and it's ultra super specialized, then these are awesome opportunities. Critical care is something that a lot of our emergency medicine residents choose to do. I spoke before about being able to be an academic, so that's involved residency program, working with medical students, working with emergency medicine residents, as well as administration. Emergency physicians are uniquely situated to be involved in administration. We're often seen as leaders in the hospital because of kind of like the front door and everybody present. We're really, really used to making complex decisions. And that's a hallmark of a good leader. Leaders often have to make decisions. Leaders in the administrative field or leaders in all sorts of other areas, you have to make decisions. You have to be comfortable with decisions you make and be able to move forward and make decisions, sometimes without a full set of information. So our emergency physicians are often leaders within the hospital. It's something that I also have a master's in public health. And so I've worked in all these areas of EM. I spent several years as the medical student coordinator at our shop. I am now in administration and I am EMS fellowship faculty. So I do a little bit of everything. And that last bullet point there on the slide, what else do ERS doctors do? Anything they want, which is so very true. Because as an ER doctor, like I said, you work shifts. So this is me and a couple of other emergency physicians. This is trackside at the Chevy Detroit Belle Isle Grand Prix. I got to ride in the car with the team who goes out and pick up drivers on the track. We get to be trackside. I was the medical director for the Detroit Marathon. Get to kind of hang out at the sporting venues and things like that. And not only that, I have a family. These are my girls. You guys have asked about work-life balance. The one in the middle there, that's Maggie. I had her when I was a third-year resident. I was also a chief resident. So she was born in February of the year I graduated residency. And so we graduate at the end of June. And then I have two more. So my girls now are 6 and 4 and just turned 3. So the fact that my schedule is like well set in advance, it's shift work. I don't have to take call. I never have to worry about going into the emergency department in the middle of the night to deliver a baby or perform an emergency surgery. It's kind of crazy to think of emergency medicine as a lifestyle specialty. I know that's kind of typically reserved for maybe like derm and ophtho where there aren't any emergencies, but I really would consider this a potential lifestyle specialty because when you leave the hospital, your time is yours. So we have, emergency physicians who do all sorts of things. So I'm here on social media. You guys can see to follow me on Instagram and Facebook. My tag is the same. My email address is there. I would be happy to talk to any of you about being a physician, having a family and being a physician. We have one of our emergency docs does jujitsu and like competes at a high level for that. We have, docs who do all sorts of things. One of our docs worked locums. So that's where you occasionally pick up shifts in other areas. She worked in Alaska for a long time. She would spend some time with us and then she would go off and work in Alaska. So the amazing thing about emergency medicine is that it opens the doors for so much. The day-to-day medicine is incredibly interesting. It's incredibly rewarding. There's something very satisfying to having somebody come in with a cut on their hand or on their arm, and you can fix it. You can sew it up and you can fix it and you can make their day better. There's something amazing about being able to get somebody's heart restarted. So I love what I do. You can absolutely have an amazing life outside of medicine and a completely fulfilling life inside of medicine. You can have a family, you can do awesome things in whatever field you choose, and I would totally recommend emergency medicine. There's a couple more things in the chat. Did I find it difficult to be pregnant during residency? Being pregnant is tough, a little tough in general. I have supportive colleagues and they were able to kind of help me through. I think there are many people in emergency medicine who find a lot of support in their work environment. So yes, it is difficult to be pregnant and be a working mom in general. I don't think it's any more difficult in emergency medicine necessarily. It just kind of depends. I got lucky. My pregnancies were pretty easy. We walk around a lot in the department, which is why I think probably all 3 of my labors were so fast, because I was always moving about. You said emergency doctors don't go on call after shift, but is that an option? So because we work shift work, we are essentially interchangeable. All of us do kind of the same thing. So when I leave from the emergency department, somebody else comes and they're fully qualified to take care of my patients. So we don't have call. There may be groups, and there are groups who would have a backup call system that if one of their emergency physicians got sick, somebody would be able to come in. So our other doctors don't take call. I do, because I am on administration. So if there was something going on in the hospital, we had a power outage the other day and we needed to divert from EMS traffic, those are my phone calls, even when I'm at home. And if we had a doctor who had a sudden family emergency or something of that nature, I would be the one who was finding somebody to replace the shift or going in to take the shift. But nope, most people don't have to take call in emergency medicine, which means like you can be at home when you're home. Common misconception about emergency medicine. That's interesting. I think that it's just the jack of all trades, master of none thing. I think people like to kind of downplay the work that's done in the emergency department and kind of hate on some of the emergency doctors, some of the specialists sometimes, but we truly, truly are masters in resuscitology and restarting hearts and intubating and things like that. So it's easy to play Monday morning quarterback on the ER doctor when you have all the test results. And sometimes that can be frustrating with colleagues, but emergency medicine is about making decisions when you don't have the complete set of information.
There were a couple of questions asking if you work with PAs and how often that happens and how they interact with you.
Yeah, so we do. We have a area of our ER which is a little bit lower acuity where our PAs typically work. We do have PAs very occasionally who work in the main area of our emergency departments. Our PAs are awesome. They're awesome. We work hand in hand. They function sort of like a resident plus. They don't have to what we call present. So like they don't have to tell me about every single one of their patients, but we're always there. If our PAs have picked up a more complicated patient or they have a question or they something they don't understand, we're there to kind of back them up. And I think that's how PAs work frequently in emergency departments or urgent cares. There's being a PA in the ER is great. You have a lot of autonomy. Our PAs are awesome. We are absolutely like very close collaborative in the emergency departments. How do you work along other physicians of other specialties? Like I said before, the emergency department is often considered to be kind of like the leaders in the hospital. Most patients pass through us before they get admitted to the hospital. And most of the time we have a great working relationship with the other specialties. To maintain that relationship, it's kind of on us as emergency physicians to have an understanding of what that specialist wants to know about the patient we're calling them about. So when I call a cardiologist to talk to them about a patient with chest pain, I need to have enough knowledge about cardiology to tell them about the EKG, about the chest x-ray, and about some of the lab results so that we can have an informed decision. Same thing like an orthopedics doctor, we need to kind of be able to tell them what the broken bones look like and kind of what we're asking them to do. And we work well with all sorts of specialties. And I think that's also sweet about being an emergency physician, that you get to interact. And there's lots of days that I will consult a specialist and we'll have a conversation and I'll kind of ask them like, okay, so can you tell me like why you're choosing to recommend this treatment or that treatment? And it's a way for me to continue to learn. Let's see.
There were several questions about your MPH because you mentioned that you had MPH. So people were asking why you chose to get that, and if you've used it as an emergency medicine physician, or kind of how it plays a role now in your career.
So I chose to do the MPH when I did it along with my EMS fellowship. So many fellowships will come with what we consider an advanced degree. So an MPH or an MBA. I knew I was looking to be in kind of higher level administration. And so the MPH was something that was great because EMS and emergency medicine have such a critical role in public health. We're kind of the stopgap. We see everything, and we are like the last resort for some patients. So my MPH allows me to kind of understand what we call the social determinants of health. So why things impact people's healthcare, what they eat, their access to food, like food deserts, right? So there's no grocery stores or very few healthy grocery stores within the city of Detroit, how that plays a role in the development of high blood pressure, and how access to care and things can impact maternal death during childbirth, low birth weight, and things like that. So my MPH is not a typical degree, like not every emergency physician has that. I chose that when I chose to do additional subspecialty training, and it allows me to understand my patients a little better. It also allows me to do a little bit of research. I do research in EMS.
There are some recent questions asking about, what do you do as an administrator in the emergency department, and how do you get into admin? Is that, you said that's kind of a choice that you knew you wanted to go into? If you could talk a little more on that.
Yeah, so I like leadership. I was a chief resident. I was like captain of the high school sports teams and things like that. It's just something that speaks to me. So as an administrator in our emergency department, we are kind of tasked with managing the other physicians. So we do scheduling. One of our administrators makes the ER schedule, so when everybody's working. We work with the nursing leadership to decide on new devices, like a new tool to put an airway in or something like that. We make decisions. We also manage when things haven't gone well. So when a patient has a complaint, or when there's been a death that maybe could have been avoided, we review those cases and we come together as a group to make decisions as administrators about, do we need to do some additional education? Do we need to change the kind of IV we're starting, or something like that? It's the higher level non-clinical stuff that I do as a administrator.
Great, thank you.
You are very welcome.
There were questions asking about, do you have family medicine physicians that end up working in the ER? Are there physicians that were trained in other specialties that work in the emergency department, or is that kind of a rural area phenomenon?
That's more of a rural area thing. There was a internal medicine physician at my department. He retired 2 years ago, and there's an internal medicine physician at one of our other departments. But it's not the norm in the urban or high level academic and trauma centers. Yes, absolutely. In the more rural areas, family medicine is often a specialty that will staff the emergency department. And that's often where like the mid-level providers, the PA and the nurse practitioners, will staff an emergency department in a more rural area. But in the larger cities and the academic centers, almost exclusively now you need to be board certified or board eligible in emergency medicine. And I've seen a couple of questions on like life and vacation. Vacation time depends on your group and how that works. I don't get any paid vacation. I have to work a certain number of hours a month over like the course of a year. So while that doesn't mean I get paid vacation, that also means I can kind of take off whatever days I want to. And so if I want to work more hours in 1 month and less in an additional month, then I can take a week, I can take 2 weeks, and I just put in my schedule request, and we go all over the place. We ski and we take beach vacations, and people do what works for their family.
So there was a question about research, and they didn't really elaborate, but I guess off of that, in undergrad at least, what kind of research, if someone's interested in emergency medicine, would you recommend trying to get into?
So we have a research department through Wayne State that does emergency medicine research. I think probably, like I said, we are resuscitologists, experts in cardiac arrest and restarting hearts. I think if somebody is really interested in emergency medicine, finding a researcher who does cardiac arrest research would be very, very applicable to any sort of emergency medicine. I see an MBA. If you're looking for administration, an MBA. The chief of our department and the president of our group has an MBA, and it's actually something that's on my radar to consider as an advanced degree for myself. To be a emergency doctor and work clinically, an MBA is not necessary. But if you want to be able to move into hospital administration, so be the president or vice president of a hospital or run your emergency group, an MBA would be clutch. And I know we had some COVID questions, like whipped through a while back. Yeah, COVID hit the emergency department harder than any other specialty. My department led our entire hospital system in our COVID response, and our PPE and our protocols and guiding literally the rest of our hospital system through. And I think that's true about emergency medicine departments around the country. Everybody stopped and turned, and all eyes were focused on the emergency providers, because this is kind of what we do. We are used to dealing with disasters. We are used to adapting and overcoming and working on the fly. And it's probably one of the proudest moments I have as an ER doctor, is being able to be involved in some of the work that we did with our department around COVID. I also got the opportunity to work with Ford Motor Company to design and manufacture face shields that got shipped around the country and around the globe. So it's been pretty cool. The silver lining of it is that we've been able to showcase how amazingly valuable emergency medicine is and the broad set of skills that we have.
Great. It's exactly about 1 hour out at our start of the session. So what advice, the last question, what advice would you leave us with as undergrad pre-meds in this time, especially now with COVID going on? What advice do you have for us?
Yeah, so I think COVID has provided us an amazing opportunity to slow down and take a step back from the grind and the fast of our lives. And I think this is a great time to really do some soul searching and evaluate what you want long term, not just tomorrow, but like 5 years, 10 years down the line. Do you want kids? Do you want to be on call? I talked before about kind of like what financials you're looking for, and then like spend some time and then make some decisions about whether you choose to do medical school or PA school, whether emergency medicine sounds right for you or another specialty. And the opportunity to engage on social media, Zoom, Instagram, Facebook, that has come out during this time, take every advantage. There are amazing physicians in all sorts of specialties who educate on social media, who will allow you like access into their lives, and you'll be able to get a really good picture of what we do on a daily basis and how it feels to be a physician. And like I said before, email me, DM me, follow me, share. I'm happy to tell you guys about what it's like to be an emergency physician, what it's like to be a mama, what it's like to have 3 girls. I'm so happy that you guys are interested.
Thank you so much for this presentation. This was amazing. You taught us so much about emergency medicine and kind of the ins and outs. And as you can see in the chat, there's lots of praise for your presentation. So thank